I must start by declaring my conflicts, which is that I'm an employee of Radius Health who makes Abaloparatide, and I own stock in the company. Please don't ask me how much the stock is worth. It's very sad. So I think one thing to just ground us all is that it's really interesting that in the United States, there are more osteoporosis fractures than there are stroke, myocardial infarction, or breast cancer in women. And I think this is really an unmet need that has not been well recognized. The costs are really tremendous. Right now, when we treat osteoporosis, often we have to start with a bisphosphonate, regardless of the initial BMD or fracture risk. That's dictated by the insurance programs that we have in the United States. But patients who cannot comply with the bisphosphonate now progress to denosumab or zoledronic acid in IV form. Anabolic therapy is only reserved for the most severe bone loss patients. If we could change this paradigm, it would be very useful, because what we'd really like to do is to assess the osteoporosis, build the bone as we monitor, and then preserve the bone. So that if we really stratify by the severity of the osteoporosis and select therapies that may be anabolic in nature for those that are most severely affected, we actually could do much more for the individual patient. So this is what abaloparatide looks like. I'm going to introduce to you. On the top you see human PTH 1 to 84, and then there's human PTH-related peptide, RP 1 to 36, long-acting PTH, and abaloparatide. And the way that abaloparatide was manufactured is that they took PTH-RP and they manipulated the amino acid sequences in it, trying to look for two different properties. One was to be more anabolic, and the other was to be stable at room temperature, because currently teriparatide you must keep in the refrigerator. And this causes a burden for patients who want to go on vacation or go somewhere for a weekend. So the abaloparatide has a 41% homology to PTH and a 76 homology to PTH-RP. How did this work out? Well, it turns out that there are two conformations of the PTH1 receptor, an RG, or good receptor conformation, because it's anabolic. There is an R0 conformation, and that is catabolic, where you lose bone. As a result of this, both PTH-RP and abaloparatide and PTH bind to the RG, the good receptor as I call it, with about the same affinity. What's different is that patients on abaloparatide bind to the R0, or the catabolic, with much less affinity, so that overall it has a more anabolic response. I'm going to explain to you a little about Active Extend. This is an interesting 18 months of abaloparatide, followed by alendronate in either the abaloparatide or the placebo group. This is the original active with a placebo, an abaloparatide, and a parathyroid arm. And then after 18 months, there was a month in order to consent the patient. There was an interim analysis for regulatory purposes at 25 months, but the alendronate continued for a full 2 years, so we have a total of 43 months of treatment, 18 on placebo or abaloparatide, and then 2 years on alendronate. This is actually the wrist data, which we think is very interesting. If you look at the 1/3 distal radius, there was no difference between the abaloparatide treated with alendronate and the placebo treated with alendronate at the 1/3 distal. And at the ultradistal, there's actually an increase in the abaloparatide followed by alendronate, even though it's not significant. It's numerically increased compared to placebo versus alendronate. Other fractures show no new vertebral fractures. This may be a little bit confusing, so let me start over here with active. This was 18 months of treatment with either placebo or with abaloparatide, and you can see there's an 86% relative risk reduction. If we then take just the extension, so just the alendronate arms, you can see there still is an 87% difference. If we take the active plus this, you can see that you get an 84% relative risk reduction in vertebral fractures if you give abaloparatide followed by alendronate compared to placebo followed by alendronate. The non-vertebral fracture risk is also quite astounding. You can see that this is the first 18 months, and we're on abaloparatide or placebo, and then at this point everyone's on alendronate, but we still have a separation of the curves with a 39% relative risk reduction on abaloparatide and alendronate compared to placebo and alendronate. I think this is one of the more interesting pieces. I know this is a very complicated slide, but I'm going to focus just right here, okay, in that last corner. And what happened is that we really didn't power the study to be able to look at hip fractures. But the regulatory agents asked us to run the study as if we had. So we ran the study, and this is all of the active intention to treat and active extend intention to treat. And what's very interesting, you can see in the placebo and alendronate arm, there are 5 hip fractures. Well, in the abalo plus the abalo alendronate arm, there are no hip fractures. So although we're not powered to look at this, there was a statistical significance among these 2 arms, which is very interesting. And I don't think if the regulatory had asked us to do this, we would have probably looked at these data. This is the treatment emergent events in the group, and what's very interesting about them is that they really don't show anything. Everyone's on alendronate essentially at this point, and you can see there's very well balanced. I like to look at the percentages here, and you can see across the way very similar. Nothing that really stands out. So to summarize this part of my talk, 18 months of treatment with abaloparatide increased BMD at lumbar spine, total hip and femoral neck, and there was a significant risk reduction in both vertebral and non-vertebral fractures. When you take that 18 months of anabolic therapy and then consolidate it with an anti-resorptive, you get further benefits on fracture risk reduction with a reduced vertebral risk reduction, non-vertebral, clinical, and major osteoporotic fractures. The overall incidence of events, serious and serious adverse, were really very similar for the study groups. Now I'm going to show you what happens when you look at abaloparatide in patients with renal impairment, because I know as our patients get older, many of them have reduced creatinine clearances. So the objective was to evaluate the efficacy and safety of abaloparatide in the active study with patients with different degrees of renal impairment. Now, at the time active was recruited, patients with severe renal impairment, defined as a creatinine clearance of 1.77 microgram per liter, and an estimated clearance of 37 microliters, less than 37 microliters per minute, were excluded. So if we divide up the treatment groups at baseline, we had 660 patients with greater than 90 milliliters per minute. We had over 1,200 patients with between 60 and 90, and a smaller group, 527, between 25 and 60. These are the age groups and the baseline characteristics, and as you'd expect, when you're looking at creatinine clearances in the under 65, the majority are here, and there's very few with reduced creatinine clearance. And when you get over 75, this is where you see the group get quite a bit larger with creatinine clearances that are a little bit more severe. As far as baseline fractures, it's very, very similar. And these are a little bit different. You can see that the creatinine clearance greater than 90 had more prior non-vertebral fractures within 5 years. These are patients who were treated with abaloparatide and their changes in bone mineral density. And you can see that at the femoral neck, lumbar spine, and total hip, there's very little difference between the 3 groups. In fact, if anything, those with the best creatinine clearance maybe have a little bit less increase in BMD, and those with worsening creatinine clearance did a little bit better. There's a reason for this. We did some population kinetics on this, and it turns out that as creatinine clearance goes lower, the amount of drug in the bloodstream goes up. So you actually get a little bit more benefit. And the only warning on that is since the drug in the bloodstream will be up, you should be careful about adverse events in patients who have a lower creatinine clearance. The incidence of hypercalcemia in this group is also very interesting. If we look at the creatinine clearance where it's very good creatinine clearance is greater than 90, you can see that very few placebo patients, very few abaloparatide patients, and a couple of 8 out of 213 patients with teriparatide experienced hypercalcemia. And this was any time during the trial, so they had blood drawn at 4 hours after dose and at 24 hours after dose. If you go to 60 to 90 creatinine clearance, you begin to see a little bit more here with abaloparatide and a little bit more with teriparatide. And those who have the most reduced creatinine clearance, again, have the highest incidence of hypercalcemia with teriparatide, as you can see. There isn't much difference between these two groups with the abaloparatide treatment arm in terms of hypercalcemia. So I'm hoping that you can see that this is a very interesting compound that has more anabolic action and can be kept at room temperature and is very, very good for our patients. Thank you.
We have time just for two very short questions. The first one is mine. Can you tell us something about